Welcome, welcome, welcome to OB Healthy in the Doctor's Lounge. I'm Dr. Omar Bey, and we're just happy to be here today to bring you Common Medical Problems Part 2. Right? We're a group of Black physicians that are here for two major reasons. Number one is to improve the health of people of African descent. And number two is to encourage young Black males to go into medicine because we need you. We need you desperately. Our webinar is every second Saturday at 1 o'clock. And if you want to look at our prior webinars, all you have to do is go to OBHealthy, obhealthy.com, and click the doctors area. And you'll see a little camera there. Just hit that camera, or you can hit the YouTube logo on the webpage, and all of our past webinars will come up. So please take a look. Topics are great. All righty. Remember to, if you go on to YouTube, please subscribe so we can continue to bring this medium that way. All right, get it to you that way. Please don't be afraid to type your medical questions in. All right, if you have a question, I don't care what topic we're talking about, type your question in. We want to answer your questions, as many as possible, because that's what it's all about. You need to get your questions answered. I know sometimes you go to the doc and he's a little busy, or he doesn't have time to explain, and he wants you to come back and all that kind of stuff. Listen, if you can type your medical question and type it in, we're going to see if we can answer it for you. All right. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, and that's true, only your doctor can best take care of you from a medical standpoint. All righty. We will have plenty of docs coming on today. It's just that everybody's busy. I'm telling you, the hospitals are jumping, so they'll be coming in as we go along. The docs that are here, we're going to introduce ourselves, and then as the new docs come in, they'll introduce themselves. Dr. Clark, please, can you introduce yourself, please?
Sure. Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work in Newark, Beth Israel. Glad to be here.
All righty. And Dr. Kendall Sprott, please.
Kendall Sprott, retired pediatrician, did 15 years of critical care pediatrics.
All righty. And I'm Dr. Omar Bey, pulmonary critical care and subspecialty of nutrition. All righty. And I'm so happy to be here, and I'm just appreciative of all the physicians that come and give their time freely to make this webinar and, just to increase the health of the people that we care so dearly for. Okay. Kevin, this is what we're going to do. Dr. Clark.
Yes,
we're
sir.
Going to do common medical problems, and I understand that you're going to start off with colon cancer. Why don't we jump right into that, and we'll go from there. All righty.
Sure. So one of the most common cancers that we deal with in this country is actually the third most common cancer is colon cancer. Breast cancer is the number one in women, prostate in men, and then lung cancer is second. But colon cancer is a close third, and it's a very important problem. Now, what cancer is, I'm just going to start in the beginning. It's a growth, and it's an abnormal growth. So when we talk about cancers or tumors, there are growths that occur in different parts of the body. And as a result of those growths, they destroy the tissue, and it can potentially spread to other parts of the body and cause problems. So that's basically what a cancer is. And colon cancer can occur in any part of the colon, which is about 2 to 4 feet in length. And there are multiple different parts of the colon, and cancers can occur all throughout. Typically, it doesn't necessarily have any particular male or female predilection. And similar to other cancers, we used to think, or at least it's mostly seen over the age of 50, 60, 70 in that particular decade. But we have been seeing it a little bit earlier over the last few years. It seems to have been somewhat of a shift, not quite 10 years, but at least 5 years. So one of the things that we can talk about it later on is the recommendation used to be to screen at age 50. And now that recommendation has shifted at least 5 years to at least 45. And that's because we're seeing cancers present at a much early age, and especially in African Americans. The presentation, similar to a lot of other cancers, if it's early, usually you have no symptoms. And in most cases with cancers, just you want to make sure you don't have symptoms. When you have symptoms with cancers, it usually means it's advanced. But that brings up the issue of screening. So we want to catch it before it becomes symptomatic and advanced. And the two areas of screening are one, colonoscopy, and Dr. Mesa, when he comes on, can talk to us a little bit more about that, and also stool testing. So those are the two areas, the two means of screening for colon cancer. Now, one of the things with colonoscopy we know is colonoscopy can detect colon cancers and polyps, and it can help to prevent colon cancers. And the way how it prevents colon cancers is by detecting polyps, which are the precursors of cancers, and removing those polyps. And in doing that, you can prevent the future development of colon cancers. Similar to other cancers, the earlier we screen for it and detect it, the better outcomes. So when we can pick it up at an early stage, when it hasn't spread or gone beyond the colon, the results are much better. We stage it, or we kind of categorize it. Sorry, based on the location. So it could be on the right side of the colon, in the middle of the colon, or on the left side. And it could be localized to the colon, or it could be beyond or spread to other parts of the body. That all determines or affects how we treat it. Now, excuse me. But for the most part, the treatment, as long as it hasn't spread beyond the colon, is surgery. And surgery removes that particular part of the colon. So if it's on the right side, we take the right colon out. If it's on the left side, we take the left colon out. There are certain cases where we have to take both sides of the colon out if it's in multiple areas. And then based on the extent, we can either add additional treatment to surgery or not. I'm gonna stop there for a second just to.
I have a few not questions but clarifications. You talked about the stool test, and I
Yes.
know that's something that you see on commercials all the time. You can take this stool test. Is that as good for detection as the colonoscopy?
So it's pretty good. I'm not gonna, well, it's not gonna miss a colon cancer. So it probably is as good as a colonoscopy at picking up colon cancers. What it's not as good as is picking up the precursors, so the polyps. So the sensitivity of, and the different types of stool tests. There's the stool test that detects blood. There's a stool test that detects both blood and abnormal DNA. Those tests, well, the stool test that detects both the blood and the DNA is more sensitive than the one that just detects the blood. But they're fairly effective at picking up cancers, but not as good as polyps in respect to the colonoscopy. What the recommendation is, when we say we want to increase screening, screening does include either the stool test or the colonoscopy. So those are both accepted modalities of screening for colon cancer. So you don't have to have a colonoscopy for screening, but if there's an abnormality on the stool test, certainly you have to have a colonoscopy after that. And the caveat with the stool test is it won't pick up, it's not as sensitive at picking up the precursor lesions, which are the polyps.
Yeah. I had another question. Oh, sorry. Go ahead.
I was gonna ask the
Yes.
provider, what are the limitations of the Cologuard test?
Well, the basic limitations is it's not going to pick up polyps. It's not going to be as sensitive at picking up polyps.
In terms of false negatives and false positives.
Right. So if you have a negative test, you can still have a polyp, an abnormal polyp there.
So the gold standard then would be the colonoscopy then, because you can still miss some of the lesions.
Correct.
But
Correct.
what he said was that you won't miss cancer.
Right, you're not
it's
gonna
very
miss a
sensitive
cancer.
in picking up cancer, but not the things that come before the cancer.
Right. But to your point, right, we've established the colonoscopy as the gold standard. And Dr. Mays is not here, but I can tell you even colonoscopies don't pick up everything. But the cases that aren't picked up are not a big cancer. It's not going to be something obvious. Obvious lesions are going to be picked up on both colonoscopy and the stool DNA test.
Mhm.
But subtle lesions, or there's some cancers that don't behave the same way as the typical cancers are, and those are a little bit problematic. They're not picked up as easily, even on colonoscopy.
So Kevin, given the increasing number of colon cancers in younger individuals as early as in the teenagers from 15 to 19 and under 25, who do you recommend get the Cologuard or the stool, given the fact that insurances probably will not want to pay for colonoscopies? Who do you recommend should get the screening for colon cancer?
So I think what we use to guide us, we're going to use the blanket age because that kind of gets the group at highest risk. So certainly anybody above 50 certainly should have it 100%. 45, I think the data in the last 5 to 10 years has shown that group, that 45 to 50 group, certainly has significantly increased in terms of their incidence. So you can argue, and it has been pushed now as a standard to shift that age to 45. Now, anything below that, sorry, we rely on symptomatology, family history, and any conditions that put them at increased risk. So if you have a family history of colon cancer, you're automatically going to be in a higher risk group, and you should at least get stool testing. If you have any sort of inflammatory bowel disease, you're at a high risk. So we use additional factors in the history to help us decide if those are groups that don't fit the traditional screening groups, if we should start screening at that point.
Okay. When you say inflammatory bowel disease, I know that's a kind of a general term the public may not understand. We're talking about, I know we're talking about um, ulcerative colitis, and we're talking about Crohn's, probably Crohn's disease. But what about irritable bowel syndrome? Is that in that category as well?
So interesting that you mentioned that, and I'm going to hold off on that question until Dr. Mazer comes. I think
Gotcha.
the problem is we don't know, well, certainly ulcerative colitis for sure in Crohn's, because those are classic inflammatory conditions.
Mhm.
Irritable bowel it's a kind of a diagnosis of exclusion after you ruled out a lot of the more common things. But I'm not sure if it's not an inflammatory process also.
Right.
Certainly a functional process, but I don't know if that in and of itself would put you at increased risk.
Right, right.
Kevin, the reason I asked you the question, a lot of people knew the Black Panther Chadwick Boseman, and he was 39 when he was diagnosed, and his cancer had already spread, and he ultimately died from it. And I guess, the question is that, even people under 40 can get it. And the stool test is is such a simple test.
Right.
And maybe we would catch some people that you didn't suspect at all, because I'm sure at the time that was diagnosed, it had been with him for a while. He was probably unaware.
Yes. Yeah. It's one of those things we want to be more liberal, but the other issue with a more liberal screening, there are some harms to screening also. So even though we do want to be more liberal to make sure that we catch all the cases, there are the false positives, and the false positives can lead to additional testing. Colonoscopies, although relatively safe, does have a morbidity and a mortality number with it. Not very high, but there are complications just from screening also. So we always take that in mind when we expand screening criteria. We want to catch everybody, but at the same time, we know that we're going to be screening a lot more people potentially that are not at risk. So that's kind of always a balance that we have to consider.
Right.
Another thing with screening, so in along the same, the cancers that happen in younger people. So when a young woman gets breast cancer or a young person gets colon cancer, that cancer itself potentially may be a little bit different from the ones that we typically screen. So meaning it probably grows a lot faster, a lot quicker. So sometimes our screening tools that we have wouldn't even be effective in those cancers sometimes, because the ability to detect it may be limited, which is something we also have to consider and reevaluate how we screen those patients that are outside of the normal demographics.
Mm-hmm. All righty. I have, before we get to the questions, because there's a couple questions are coming up and we're going to get to those. Just, Kevin, what would be the symptoms that somebody would look for, if they suspected that there may have something wrong with the bowel, like cancer? What would the primary symptoms that you see?
So the alarming symptoms, we always say pain, and everybody has pain now and again, but pain that's kind of persistent. So if you have pain that doesn't go away or goes away and it comes back, but it never quite goes away completely. That's one thing to be concerned about. Unexplained weight loss. So if you're not planning on losing weight, but you notice your appetite is not quite where it used to be, and you're losing weight despite keeping up your same diet, that's something to be concerned about.
Mm-hmm.
If you have any changes in your bowel habits, so if you notice you were regular before, you went to the bathroom 2 to 3 times a day, and now you can only go once or twice a week, that's a problem. If the caliber of your stools have changed, that's an issue. If you have any sort of bleeding, so rectal bleeding, those are all alarming symptoms that need to be evaluated.
Excellent, excellent. Dr. Mazer, I mean, excuse me, Dr. Ali has come in. Dr. Mazer Ali, that is. What I'm going to do is, I know he's got his mic muted right now, but what I'm going to do is I'm going to have you and Dr. Court introduce yourself. Dr. Ali, since I'm talking to you and talking about you, why don't you introduce yourself first, and Dr. Court will second, and then we'll get to some questions. So I'm glad you come in, because the questions are more up your alley. Okay.
All right. Can you hear me okay?
We can, yes.
All right. Good morning, Dr. Bay. Good morning, everybody. And my name is Dr. Mazer Ali. I'm a gastroenterologist from Southern California, sunny California, the West Coast Scripps Clinic. Thank you for having me.
All righty. And thank you for coming and giving of your time. Dr. Court, you're next.
James Court. My practice in East Orange, New Jersey. My specialty is internal medicine, adults only.
All righty. Thank you. Thank you. We have a few questions. I'm going to come a little closer to the computer because my I'm not even going to call them trifocals anymore. It must be at least 5 levels of to see, but we're going to read this. My doctor said that I am hold on just for a second here, guys. My doctor said that I no longer need to do colonoscopy because of my age, 83. Is it because risk of developing colon cancer is very low? I am a very healthy female. Hypertension and Barrett's esophagus are my health challenges, which are managed by meds. Okay, so I don't know if Kevin or Mazer, whichever want to jump in on this one. But it's a good question.
Kevin, you want to start, and I can
Sure.
add in.
So
You can still get. Go, you go first. I was going to go to see, but
Go ahead, Dr. Court. Get your question.
Dr. Court, go ahead first. Dr. Court.
you can still do it if you have symptoms, if you see rectal bleeding or change in bowel habits. Yes, you can do it. Although insurance companies usually after 75, they don't like to do screenings. But you can do this procedure if you do have symptoms.
Mhm.
Right? There's
So one of the
no
things
question
that
about that.
the age, the disclaimer, what they say is after a certain age, it's at the discretion of both the patient and the physician. And the reason is we don't have the data in certain age groups. We have to extrapolate, and we have to interpret it as far as what the risk is. Now, I haven't said that we don't use any particular age as a contraindication to do screening because it has to do with your overall health status and at what point are you going to be at risk or projected to have something. So if you're 83, as the question says, and you are healthy and your projected lifespan is another 5-10 years, then benefits from screening is going to be there. If on the other hand you have other conditions that outweigh or take precedence over screening for a condition, it's more of a discussion that you have as far as what the benefit's going to be. Now, you certainly don't have to have a colonoscopy to be screened for colon cancer. As we spoke about before, Dr. Ali can come back to that question you had, Omar. You can have stool testing and other things for screening also.
Okay.
Yeah, so I agree, and this is a question that we get asked often when I see patients, and what age do we stop? And we have some guidelines that we follow with this, and typically what I tell patients is that at the age of 75, we can continue screening, but it is more of an optional exam and dependent on your overall health. And the reason for that is because, everybody's a little different, right? If there's somebody who has underlying cardiac issues, pulmonary issues, or somebody who may have balance problems, doing a bowel preparation could be a challenge and maybe a safety issue. But what I tell folks all the time is if you feel like you've got a good 10 years in you and you feel healthy and you want to keep on screening, we keep on screening. Now, other factors that play into this, though, are if people have a history of polyps or a history of cancer, a family history, that may warrant us to continue screening if somebody would be willing to do that. And it's something that usually the insurances will or can still cover. I usually don't have a problem with it. And as long as we justify as well and somebody's healthy and we can keep screening. Now, there are a couple of other options, as Dr. Clark mentioned. Colonoscopy is what we call the gold standard way, right? This is probably one of the best ways that we can screen for cancer because if we find a polyp, and polyps are these little growths that grow along the lining of your colon, and they grow innocently over the course of years, but then some of these polyps have the potential to grow further, mutate, and turn into cancers. That process could take somewhere up to 10 years. So that's why our surveillance guidelines would say if somebody doesn't have a family history and there are no polyps found, we do these procedures every 10 years, and that's safe. Now, Other options, though, there is something called the FIT test, which is a test that checks the DNA. You may even see some commercials for something called the Cologuard test, which is very similar to a FIT test, where they check the stool DNA. And from that, you can also detect cancers or what we call advanced or larger polyps. Now, that test is indicated in somebody who is what I call average risk, where there's no family history of colon cancer, or in the past, if there's no prior history of colon polyps. If you have a family history, or if you've had polyps that have been removed in the past, which are the kind of what we call the precancerous kind of polyps, then usually it would not be advised to do a stool test, and we go straight to a colonoscopy.
Excellent. All righty. Let me get and an excellent answer, I must I must say. We have another question. Explain the leaky gut and how serious. Explain leaky gut and how serious is it? Let me see. What are the symptoms of a leaky gut? Now, you're way outside of my area of knowledge. So, Dr. Ali, I'm gonna leave this to you.
Okay, so it's a very good question. And there's a lot of information out there. You know, what I find in GI, right, is that people suffer from chronic GI issues. It's one of the most common things that we deal with. If it's not reflux, it's abdominal pain, bloating, gas. You look online, we see things such as leaky gut, you know, and it's actually a very common term that's used. But what I would say about this is, you know, you're going to also get a lot of opinions amongst doctors as well. And there's a lot of variation in how people interpret that term. Now, for me, in my perspective, when I view somebody with the term leaky gut, essentially what that is a little bit more synonymous with is something called irritable bowel syndrome. And this is a problem where there is a motility within the gut, meaning your digestive system either may move too slow or it may move too fast. And people have different speeds at which their bowels may move, and things that can cause that dysregulation in the speed is very much an interplay between your autonomic nervous system, or the brain, and the gut. There's a very strong connection with the brain and the gut, and this is not something that we particularly control. It's something that our autonomic nervous system controls. And how somebody may have present in terms of symptoms, it could be either bloating, gas, diarrhea, constipation, combinations of those, flipping back and forth between diarrhea, constipation. And where that term leaky gut comes from is essentially where there's a problem with that motility. And as we eat certain foods, because that motility is altered, you may not be digesting it very well, right? Particularly foods that are a little bit harder or take a little longer to digest. If your bowels are moving a little too fast, you have issues with diarrhea. If you eat certain foods that take a little bit more out of breaking them down, then they get into the colon prematurely digested. Bacteria in our gut, which we should all have, right? It's part of the microbiome, will then take those larger molecules and try to digest it themselves. That leads to production of things like hydrogen gas, which causes bloating and gas. Methane can cause more flatulence or diarrhea or constipation. So, I use it. It's a very complex term, and I could talk about this for hours. But kind of in the end of the day, I think where it all comes down to is this term of irritable bowel syndrome and leaky gut. Very similar terminology.
Mm-hmm.
A quick question,
Clark,
since you mentioned it.
Mm-hmm.
Before you introduce Patrick, before I forget. So we had a question earlier about inflammatory conditions and the risk of cancer. So we know ulcerative colitis certainly has an association. Does IBS, is there an association or increased risk with irritable bowel?
No. So because irritable bowel syndrome is not necessarily inflammation in the gut or the colon or the bowel, where you see the difference is in inflammation. Either it could be inflammation from chronic infection, autoimmune disease, Crohn's and ulcerative colitis, or autoimmune diseases where your immune system is attacking those portions of the gut. It can cause very similar symptoms, but that's where there's active inflammation, ulcerations, and that's different. Irritable bowel syndrome, there's not inflammation, but there's a motility issue that's creating that problem. So usually in that scenario, because we don't see an increase in the inflammatory cascade, we don't see that increased risk of cancer progression, right? So there's not an increased risk for cancer. However, in irritable bowel syndrome, in anybody who we always will recommend the appropriate cancer screening still, like, if you're of age 45 or older, colonoscopy, things of that nature.
Excellent.
Since you mentioned it, just to follow up, we had a discussion about the age to start. And since we're seeing younger patients, what's your take on that?
So, for years, right, we had our guidelines told us that it was for men and women starting at the age of 50. But the data always showed us that Black patients had a higher rate of early colon cancer. There was a higher risk factor. There was a risk factor there. So our guidelines always said, well, 45. Unfortunately, not everybody knew that or recommended that, advocated for that. But what we are seeing now in some of our more recent data across the board is that cancers can occur at an earlier age. And our newer guidelines have adopted, and they allow for screening starting at the age of 45 for men and women. If there's a family history, then usually we would start in the family history constitutes as a first degree relative, right? So mother, father, sibling, and a first degree relative who developed the cancer before the age of 65, right? So if it's somebody that may have developed it later on in life, that doesn't put that person at necessarily at an increased risk, as opposed to some of the younger, the earlier onset cancers. And we would start at the age of 40. However, it would be or 10 years prior to the age of diagnosis. So say there was a sibling that was diagnosed with colon cancer at the age of 40, then the first degree relative would start at the age of 30.
Excellent. Excellent. There's another question here. Let's get to this question. Should a person diagnosed with diverticulosis be a candidate for colonoscopy?
Absolutely. And diverticulosis is very common. I would say majority of people over the age of 50 will
Could you
have
explain
some
what it
level.
is, Mazer?
Absolutely. So patients over the age of 50, most will have diverticulosis. And what they are, there are little pockets that develop in the lining of the colon. As we age, we just develop these little pockets. And part of it is the pressure system changes as we get older, and these little pockets just kind of develop. Now, also with patients or people who don't have a lot of fiber in their diet, right? They have an increased risk of developing more of these. Now, most people who develop these little pockets, they're called diverticulosis, right? Or diverticula. And they usually create no problem for people. Most people will do fine. They have them. And whenever we see them, we always recommend a high fiber diet or a fiber supplement. And ideally, we recommend about 25 grams of fiber per day, right? That's the ideal amount of fiber that we should have within our system. And that can prevent new ones from forming or complications from developing. Now, what are the complications of these diverticula or diverticulosis? One could be what we call diverticulitis. Diverticulitis is inflammation of the diverticula, just itis at the end, like appendicitis or gastritis, inflammation of. And diverticulitis is where one of those little pockets becomes infected, and it could lead to a lot of pain, discomfort, fevers. You may notice if you push on your belly, they may get tender. And typically, depending on how severe the pain may be, we usually would diagnose it with imaging. We would see on a CAT scan, the inflammation could be present. Typically, the treatments are either bowel rest, fluids, and the infection could resolve on its own, or the inflammation could resolve on its own. But if things are more severe, it may require a course of antibiotics. Not all diverticulitis requires antibiotics. If it's a simple course, then it could be managed conservatively. But if it's a more severe course, then it would require some antibiotics. So that's one of the complications that can develop from diverticula. The other that we commonly see is something called a diverticular bleed. And this is where that little pocket interfaces with a blood vessel, and that blood vessel becomes exposed, and it can cause bleeding. And you may notice a lot of blood in the stool, bright red blood or maroon colored stools. And typically if that happens, it's a medical emergency. You need to go to the hospital. That's a very rare complication, but it happens. It happens often enough where we do see it in the hospital setting. And, again, it's something that would require endoscopy to stop a bleed potentially, or it may stop on its own. But those are the two major complications, or the two complications that can develop from diverticula. How rare are they? They're very uncommon. Most people won't have them. They usually are not an issue. Should you still do a colonoscopy? Yes, we still follow the same colon cancer screening guidelines. Now, if somebody develops diverticulitis, that inflammation of the diverticula, we usually would recommend a colonoscopy if they have not had one within a few years, just to make sure there's nothing else that could be driving that bout of infection that happened. But we don't do it immediately. We allow for the colon to heal, that diverticulitis to heal first, because if we go in with a colonoscopy with the device, we want to make sure the integrity of the colon is strong.
Excellent, excellent. Let's take a break here. Dr. Patrick Anderson, you came in. Can you introduce yourself? And Patrick, before you introduce yourself, last show on the we hit common medical problems as well, but you were last, and I don't know if you got an appropriate time to express what you wanted to express. So introduce yourself, and if you want to add something to that, please do. Dr. Mazur, after Dr. Patrick Anderson, I know what we're going to talk about.
Okay.
We'll talk about GERD. So Patrick, please introduce yourself.
Hi, everyone. It's Patrick Anderson. I'm a GYN oncologist. I take care of women with cancer of the reproductive system. It's an honor to be here. I can't recall what my point was or my commentary was going to be in the last session. However, but with respect to screening and kind of working backwards with respect to screening, as a GYN oncologist, sometimes we deal with cancers as not just one, and specific cancers, not just as one entity, but as a spectrum of malignant or cancerous conditions. And when we speak about screening for colon cancer, if I could just get Dr. Mazur's input, occasionally I will operate on a patient for ovarian cancer or endometrial cancer, cancer of the uterus. And when we do the genetic profile on the cancer, there are certain markers that we look at, some of these mismatch repair genes that actually suggest that those patients may be part of a cancer syndrome. The one that comes to mind is the hereditary non-polyposis colon cancer, or Lynch syndrome, which is an autosomal dominant gene. So if Dr. Mazur can give me some input as to patients with known HNPCC or Lynch syndrome, when do you start screening those patients and family members of those patients? Because that information may filter through to you because of a family member with another cancer.
So family histories of cancers, yes, like things like colon cancer syndromes. There's something called HNPCC, which is a hereditary non-polyposis colon cancer syndrome. These are conditions, or this is a familial related condition where people have an increased risk for colon cancer. It could be associated with ovarian cancers, gynecologic-based cancers, gastric as well, or actually not gastric, but we call them ampullary cancer. Sometimes there could be a variance with brain cancers as well. They're rare, but when they occur and where you see these familial patterns, we usually would start screening sooner for these patients. Again, it's 10 years prior to the initial diagnosis. If there's a confirmed diagnosis of HNPCC, usually when we confirm it in a family member, it's with genetic counseling. So I guess first, in terms of thinking about, like, if you've got a family history of colon cancer or gynecologic based cancers, we usually call, if it's something that it affects 3 generations, meaning it occurs in your generation and maybe it occurs at your parents' generation or maybe your grandparents' generation, that usually would, for us, trigger it would trigger a genetic counseling, and you get some blood and you actually check for some of the genes that can be associated with this. And then when we start cancer screenings as well, we usually would start between the age, it's usually every 2 years, depending on if they test positive for it. And you start somewhere between the ages of 20 to 25. So you start much sooner in life.
And in this scenario, we don't use, we go to the gold standard. We go straight to colonoscopy.
Correct. There wouldn't be an eligible candidate for the fit testing or the stool tests or anything else. We go straight. We do straight to the real deal. Now, the other thing that I would recommend that we also do, right, in some of these syndromes, we also would do an upper endoscopy to screen for stomach and ampullary cancers. The ampulla is a little organ that comes out from the biliary tract. So we would also do an upper endoscopy at the same time as a colonoscopy.
Excellent. Excellent. Dr. Mazer, while you're on a roll, and we love it when you come on and and give us this time. Um, we had talked earlier about GERD or esophageal reflux. I remember and Dr. Court, last time we were in Guyana and with the medical mission, and the number of patients that came through that had complaints of esophageal reflux was quite a large number.
The
So
term that they use is burn stomach.
yeah, that's what they call it. All righty. And I think in the States as well, I think so many patients come, and from a pulmonary standpoint, I mean, it's one of the things that and a major trigger, I should say, of bronchitis or hyperactive airway syndrome. So, doctor, I need you to just give your 2 cents as far as GERD is concerned, or esophageal reflux, and let's get an understanding of what it is and how we can manage it.
Sure. And, this year, unfortunately, I was not able to join the medical mission in Guyana. But when I have gone in the past, it's probably the most common symptom that people report. And, across the globe, reflux is probably one of the most common conditions that affects us. It affects most people at some point, sometime or another, they may get reflux. And what that is essentially is where there's acid in the stomach that comes up and spills over into the esophagus. Now, your lining of your esophagus is different than your lining of your stomach, right?
Doc, explain the anatomy there, because
Yep.
what's
So
the esophagus, where is it, and the back of the throat going down. Just explain it so they'll understand.
absolutely. So when we eat something, right? We take something, we eat it, we swallow it, it goes down. When we swallow it, our muscles take that food beyond the mouth into the throat and then into the esophagus. And the esophagus is the tube that lies kind of behind the windpipe or the airway, right? The trachea, and it takes that food down into your stomach. Now, in your stomach is where we make acid, and we all make acid as part of a natural physiology, right? And our bodies make acid to break down foods into its components. So we eat like carbs, we eat proteins, we eat fats. And when we eat those foods, the hydrochloric acid in our stomach will break down those foods into the components that it needs to break down to, right? So complex carbohydrates get broken down into its sugars so it can absorb into the small bowel, proteins, etc. And then all of that food in the stomach advances into your small intestines, which is where we call the absorptive powerhouse. This is where all of your absorption occurs, where you absorb fats, you absorb proteins, you absorb the carbohydrates, and you absorb all the nutrients that you need. Now, what can happen though is when we eat, our stomachs will start creating and building, releasing more acid. And when our stomachs release more acid, then there usually is a barrier between your esophagus and your stomach, and it's called the lower esophageal sphincter. And it's a muscle that stays nice and tight, and it's usually very close. But when we eat, then that muscle relaxes and food passes through that muscle and it goes into your stomach, and then it'll close back up again, and it keeps that barrier in place. But sometimes if our bodies create more acid from eating, Or what most commonly happens is the sphincter itself, that muscle just transiently relaxes. It allows for acid to spill over into the esophagus, and that can burn, and that's called heartburn. And the lining of your esophagus is very different than the lining of your stomach, where it's designed to hold acid. Our bodies are designed to hold acid. Acid is not bad. Acid is that's kind of the natural physiology of what our stomachs do. Now, that acid, if it spills over and is exposed into the esophagus, then you can develop pain or discomfort. Now, symptoms of reflux, when we think about reflux, we think about this symptom that there's heartburn, right? Up and down, burning in the chest. And that's probably that is the most common symptom that we have, right? About maybe 60+% or so may have that feeling of heartburn. But that's only one symptom. Other symptoms of reflux, when we think about the umbrella term of reflux, heartburn is one symptom. Another could be pain or discomfort in the lower part of the abdomen. People may even present with feeling bloated or gassy, distended. People may have a sour taste at the back of their throat. We call that water brash. And sometimes people may even present with a cough, a chronic cough. It's actually one of the most common causes of a chronic cough, a dry cough. Sometimes people could present with wheezing. It could be a manifestation of an asthma as well, reflux. And then sometimes we even see people not have any symptoms at all, but they may go to a dental office for a routine exam, and the teeth may be, the enamel along the teeth could be eroded, which means there could be some levels of reflux. So those are the common symptoms that we can see when it comes to reflux.
Excellent.
Are there some foods that exacerbate the reflux? And in terms of eating, are there, because most people that complain about GERD or reflux, it happens at night. So is there some recommendation as to how often, how much, and when to eat, when not to eat?
Absolutely. So as we eat, right, food, acid is released. Now, there's certain foods that may trigger more of that, right? Acidic based foods, lemons, orange, like things that are a little bit more acidic, or what I call red sauces. A lot of times red sauces can trigger more reflux. Fried foods, oily based foods can also trigger more of that because your body needs more acid to break down those components. The other part of it is how much we may be eating. Sometimes if we eat too much and the stomach is too full, right, it can cause more distension. That distension may allow for that sphincter that stays closed to be a little bit more open, preempting to reflux. Sometimes when we eat later at night, that could be a common trigger. And why? Because I always think of reflux as a gravity-based condition, and meaning that acid kind of goes down and stays down as we stand upright, right? Gravity keeps things down and where they need to go. But at night, what do we do? And think about kind of our culture in general, right? We are working, many Americans, most people work all day. If you're like me, I don't eat through the day because I'm on the go. And then what do I do at home? I'm hungry. So I eat everything I could think of. And then what do I do immediately after I eat? I lay down. So I take my body from an upright position and I kind of go down. And so when we sleep at night, right, especially if you eat later, you're kind of coming to a flat position, and more of that acid could just spill over and cause more of those symptoms. That's why a lot of people can have heartburn at night.
How do you treat it?
So when we think about treatment for reflux, there are a lot of things out there, and there's a lot of information out there too. But I say some of the more conservative things that you could do if, a lot of people don't want to be on a medicine, right? So some of the things that we recommend are adjusting the foods that you may be eating, smaller, more frequent meals through the day. So instead of 3 larger meals of the day, if you kind of space those out, it doesn't overflood the system. It doesn't fill up the stomach as much. That can help. When at night, having your head of bed elevated about 30 degrees can help with reflux symptoms as well. Now, there are medications out there, right? So Tums is probably one of the most common things that people see, and they're taking them through the day. And all that is, it neutralizes the acid that's in the esophagus. It's very short-lived, meaning that it can give people some more immediate relief. but it's not necessarily something that's great from a long-term perspective. If people have reflux intermittently here or there, once every blue moon, certain foods, predictable, you can get away with it. But if sometimes people have reflux regularly, every day, a few times a week, and that may require medication, other medications, stronger medications. So there is one that's called an H2 blocker, and these are medications like famotidine or Pepcid, Zantac, which is no longer on the market. But what they do is they bind to a receptor at the proton pump itself in the stomach, and it shuts it down, or it slows it down. And that can help with reflux. It's very effective. There's another class of medications that's probably the most commonly used, and those are called proton pump inhibitors, or PPI medications. These are commonly known as omeprazole, Prilosec, Nexium, Protonix or pantoprazole, Asifex. There are a lot of different brands out there. They all are very similar in its efficacy, and they're probably the most efficacious medications that we have to treat reflux. And typically, we would recommend once a day. You could take this medication 30 minutes before your largest meal of the day is how it works most effectively. And if your reflux symptoms are not very common, or they're a little bit more out of the blue, then you could take it as needed on demand. And even though if it's not within that 30 minutes, that's okay. If people, I akin reflux like a headache. You get a headache, you take a Tylenol. Kind of similar concept. But if you notice that you're having reflux more than a couple times a week, and it's a little bit more regular, then an antacid medication such as the Pepcid or omeprazole or classes of those medications are appropriate to take. Now, these medications, I'll jump right into this, have gotten a very bad reputation over the years. Now, these medications also have been out since the 90s, 80s. They're 30 plus years old, 40 plus years old. We've been using them a long time. They used to be something that the doctor used to have to prescribe, but now these are readily available at any drugstore, grocery store, Costco, etc. Now, over the years, you may go online, you may say these medications may not be safe because and some of the things that have been reported are things like hip fractures, osteoporosis. There was a risk of heart disease. There was one that was reported a risk of dementia, hip fractures. And what I could tell you, though, about the literature that's been published is that, the studies have been what we call retrospective association-based studies, which means it's a study that's looking at large populations, multiple medical issues in these patients, and they find there may be this link, but it's not something that's been directly studied with that medication. And we, at this point, do not have any studies that show a true cause and effect relationship with any of the reported adverse events and these medications. Association does not equal causality, which means I may be wearing a blue sweater, but it doesn't mean I love the ocean, right? We haven't had quite that link that shows that. And there's a risk-benefit ratio of being on these medications for things like quality of life, symptomatic control, and and just kind of the safety of it. Overall, they're safe, and they're very efficacious to use. We just use the lowest effective dose of them.
Dr. Sprott, your hands up.
Yeah, one of the things that in pediatrics we commonly see is reflux, especially in babies. And what we tend to think of is if a baby burps, sometimes they have these wet burps, but the same thing happens. That sphincter that Mazur spoke about, that sort of keeps food that is in the stomach from getting up into the esophagus, it opens up and it relaxes. We don't see any of those complications associated with acid reflux in babies, because what normally happens is that the baby is eating every 2 to 3 hours, and the baby's taking formula and milk. And the milk sort of helps to neutralize. It's a slightly lower, it's approximately the same pH as normal, and so it balances it. And so when the baby burps, very often it may come out, the baby may spit up. And that's different than vomiting. Vomiting is sort of a reflux that's triggered by the brain, by a center that causes you to vomit, and that is retching. These babies don't vomit. They just have this reflux and it comes up. And what we normally do is we ask for the parents, after the baby eats and the stomach is distended, is to hold the baby up and lean slightly forward and pat the baby on the back. What that does is allows the milk that the baby swallowed to go into the stomach and to have that air that's in the stomach at the top where that esophagus is. And so if the esophagus, the esophageal sphincter opens and there's air there, then the baby will burp. If there's milk and air there, then they'll burp and there'll be some milk that comes up. But usually it's not sort of projectile. It just comes up and sometimes the baby will spit it up or sometimes the baby might swallow it back down. But it's usually not something that is really worrisome. And again, what we normally do is we tell the parents, just try and burp the baby. If the baby's having it a lot, try and burp the baby in between before the baby finishes the entire meal. So we say that it's the unopposed acid. And another important factor of the acid, other than the digestion, is a lot of bacteria. A lot of the germs that you might swallow when you eat are killed by the acid in the stomach. And so that becomes an important factor that in terms of health-wise, especially way back in the day where we didn't have a whole lot of antibiotics and everything else, that acid in the stomach killed bacteria. But there is a bacteria that has been associated with causing problems, ulcers, that somehow or another is able to survive in that acid environment. Dr. Mazur, you want to talk about that?
Sure. So, you're talking about H. pylori, right? The bacteria?
Yeah.
Yep. So there is a bacteria that can live in the stomach commensally, right? And it could be there for years for some people, but it's a bacteria that's called Helicobacter pylori or H. pylori. And it's a very common infection. And in about 15 to 20% of people who have H. pylori, they can develop an inflammatory reaction to that. And they can develop things like inflammation or gastritis, inflammation of the stomach, ulcerations as well. And that can potentially also increase those symptoms of acid reflux or burning or pain or discomfort. And this bug is a very common bug. We see it here. We see it across the world, and in some populations in Asia, the prevalence is almost as high as up to 50%. It's very high. And but whenever we see this infection, and if it causes symptoms for people, we do eradicate it, or we try to eradicate it with a round of antibiotics. And typically it's a bug that may be a little bit more difficult to treat. It has got some resistance patterns. It's a classic example of why we're very judicious about, careful about using antibiotics, because people can develop resistance to things, right? But this antibiotic usually to treat this infection usually requires 2 or 3 antibiotics, may require 2 weeks of therapy. Sometimes we have to check to see if it's eradicated. And how we check it is usually with a stool test. We could also there's a breath test that you could breathe into a bag and you can detect it that way. And the third way that we check for it is with an endoscopy. So, and then I think maybe I should mention, where and when do you get an endoscopy if you have reflux? Which is, when people have reflux that doesn't get better.
Can I interrupt you just for a minute?
You bet.
What is an endoscopy?
Thank you. So an endoscopy is where, kind of like a colonoscopy, we go in and we take a look from the bottom. That's where we take a tube with a camera at the end, very similar to the colonoscopy, but we go into the mouth. And we look inside the esophagus, we look inside the stomach, a little part of the small intestines as well. And we look for things like ulcers, inflammation, herniation, cancers, things of that nature. And when we would consider this is for people who may have really bad reflux symptoms, or sometimes when people get really bad reflux, they may start developing issues where they can't swallow. Things may get stuck. Like if you're eating something like some bread or some meat and you feel like it just doesn't pass all the way through, something is blocking that pipe, that warrants an upper endoscopy. Sometimes if there's a lot of nausea, vomiting, and we're not quite able to figure out why, this will help us in figuring out what's going on. Now, when people have reflux for a long period of time, then a lot of times in that scenario, if people have reflux for a long time, for years, or they're not better with the medications, I usually would do an upper endoscopy. Now, when people come in for a colonoscopy, I always ask them, do you have reflux? And if they've got reflux for years, then I also do an upper endoscopy at the same time. And the reason for that is 10% of people who have reflux, 10%, 1 out of 10, can develop a condition called Barrett's esophagus. Now, Barrett's esophagus is where that acid gets exposed to that esophagus, and our bodies are smart. Our bodies are very adaptable. The lining starts to change to look like the lining of the stomach to accommodate that acid. It's kind of a natural mechanism and evolution that the esophagus does. The issue, though, is that when people develop Barrett's esophagus, they have an increased risk of developing esophageal cancers. So that risk is overall very low, less than 0.1% per year. However, it's still higher than the general population. So whenever we detect Barrett's, it's something that we could see on an endoscopy. If we would go in and take a look and we take a little biopsy to confirm it on a pathology specimen, then what that warrants are 2 things. Number 1, it warrants that you're somebody that needs to be on an antacid every day, right? To bring down that acid. And the best antacid at that point would be what I call the proton pump inhibitor, like the omeprazole or the Prilosec, a medication in that class. And number 2 is that you're somebody that would need a surveillance, meaning that we need to go back in and take an eye and keep an eye on that thing. And usually the surveillance is somewhere between every 3 to 5 years.
Ali, one question before you move on. Is there any role for medications such as Reglan in treatment of gastric reflux?
So good question. And, Reglan is a motility agent, right? It's something that helps in that clearance. And we don't necessarily use it in the setting of reflux because we have other medications that control the reflux. Reglan is more used in the setting of somebody who may have what I call a gastroparesis, which is a condition where there's that motility problem where things are moving through much slower. I don't use it in the setting of reflux really at all. I actually rarely use Reglan much. I use it more in the refractory cases potentially. And the reason for that is because of the side effect profile with Reglan. There was and there is a black box warning with some neurologic based side effects with chronic use of Reglan. So I don't use it regularly for this, no.
All righty. We have several, thank you. We have several hands up, but we're at our halftime. Let me do our halftime, and then we're going to come back. Dr. Patrick Anderson, you'll be first. Dr. Sprott, you'll be second. And and we have some questions as well. So we'll get those done. Dr. Mazur, you're amazing. That's all I can say.
You guys are out too. By the way, Dr. Sprott, congratulations on that award.
Thank you.
Yes.
Yes.
So, our teacher.
Very well deserved.
What I'd like to do is I'd like to see if each of us can reintroduce ourselves. I want to get my papers together here. All right, Dr. Anderson, please.
Yes, Patrick Anderson. I'm a GYN oncologist. I work in the Barnabas Health System based out of Newark, New Jersey, Newark Beth Israel Medical Center.
All right, Dr. Sprott.
Kendall Sprott, retired pediatrician. I did 15 years of critical care pediatrics and more of general pediatrics.
All righty. Dr. Mazur, one more time.
Hi, Mazur Ali, gastroenterology at Scripps Clinic in San Diego.
All righty. Dr. Court.
East Orange, New Jersey. My specialty is internal medicine. I only treat adults.
All righty. And Dr. Kevin Clark, please.
Dr. Clark, good afternoon. Surgical oncologist. I work at Newark Beth Israel.
All righty. And I'm Dr. Omar Bey, pulmonary critical care, subspecialty in nutrition. And just so thankful all these brothers are here and we're doing some good work. All righty. Dr. Mazer, I want to tell, this is an anonymous attendee, says, Dr. Ali, we missed you. How you like that one? Hope to see you next year. And we're growing bigger and better, right? They're referring to the guy in the medical mission, and I as well hope to be there next year as well. So we're going to rock and roll, just to let everyone know.
What's a promise?
I promise, God
We're
willing, I will be
promising.
there.
We'll be
I was
there.
with
We'll
you
be there.
all in
We're
heart.
rocking. All righty. Let me just say this: this webinar is every second Saturday of the month at 1 o'clock. Please, you can sign in so easily. Just go to obhealthy.com and hit the doctors tab, and it'll allow you to register and come on. And please, I'm going to tell you again, even those who are on the webinar right now, please do not hesitate putting your questions in. We want to answer any and every question. It doesn't have to be on the topic that we're covering. Just put your question in so we can answer them. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor truly can take care of you from a medical standpoint. All righty. And I'd like to thank OBHealthy for allowing us to bring this project to you, this webinar to you. Without them, we wouldn't be able to do it. All righty. Yeah. Dr. Patrick Anderson, you're up.
Yes, as a advocate for women and healthy women, Dr. Ali, with respect to gastroesophageal reflux, pregnant women is another group of patients who often have this transient GERD, and it relates to one hormone that causes smooth muscle relaxation, and as a result, impacts the rigor of the gastroesophageal sphincter, and as a result, and later on in pregnancy, as the uterus grows and the intra-abdominal pressure increases, it also changes the pressure dynamics between the distal esophagus and the stomach. So you get a lot of that gastric content up in the esophagus.
You're correct. And I actually see quite a bit of pregnant women that come in because they've got really bad reflux. And, a lot of times in that scenario, we try the best we can to manage it with things like diet and, if they could use Tums to get them through it. But a lot of times what they really do need, just from a quality of life perspective, especially with the nausea, the vomiting, and it's so important they keep their nutrition up, right? They need those nutrients for the baby to develop. I do use antacids. Like I would use something like an omeprazole or a Prilosec in those scenarios, and I would use it transiently to get them through. It's something that is safe, and my OBGYN colleagues, they oftentimes, we talk about it, and we work with putting them on a medication at least to get them through it. And a lot of times, maybe in that second trimester, third trimester, it may get a little better for some. Sometimes it gets a little worse. It's that first trimester, but everybody's so different.
I have a question as well. In nutrition, we see these hyperemesis gravidarum, and is there something that, well, I know from my perspective, I try to handle it the best I can as far as feeding people, but from your perspective, is there anything that you can do? Dr. Mazer.
Oh, sorry. Yeah. So from feeding, are you talking about like inpatients when they admitted to the hospital?
Well, basically, a lot of them are. Some of them actually go home with IV fluids and trying to maintain. But is there anything from a GI perspective we can do that would help decrease the amount of vomiting? Either, you know what I mean? Just I'm
Yeah.
not sure. That's what I'm asking.
A lot of times when people are admitted to the hospital, right, for whatever reason, their body is also in a high stress state, and their body creates more acid, and that probably adds to this. So what we often recommend is what I call a GI prophylaxis, meaning I put them on the antacid medication. And it's usually a proton pump inhibitor like the omeprazole, the Prilosec, tries to keep things down. It doesn't hurt especially in the setting of nausea, vomiting, and you're really, that nutrition is so important. Even if you can give them a little something to control the nausea, like Zofran, just for now to get them through. Now, if things aren't better, right, or you get worried about things like an ulcer because the symptoms are very refractory, very low threshold to do an endoscopy, especially if they're admitted to the hospital, to look and see if there's anything else that could be driving any of those symptoms.
Right. And I should step back too, because I said the big word, but what we're talking about is extreme vomiting during pregnancy.
Oh, during pregnancy.
You know what I
Yeah.
mean? I said the word, and hyperemesis. What?
Yeah.
That's
But
what. That's what it
in
is.
that setting, though, antiemetics probably more so than the proton pump inhibitors are more helpful. And the question becomes which one of those antiemetics are safe, because hyperemesis does tend to happen early in pregnancy when development of the organs in their early stage is important. So usually many women will defer using medication and try to tough it out. But sometimes when the acid gets up in the esophagus, it becomes unbearable, and then they come into the hospital, for pain and concurrent dehydration.
Right. Patrick, I'm going to antiemetic. I mean, we're throwing these words around. Something that prevents.
These are
Say
medication
tell
that
us what
helps with
that is.
nausea and vomiting.
Right. A medication that helps with that. I mean, what we're going to try to do is we're going to try to use less. Well, put it this way: if we say a word that may not be understood, let's explain it. I'm not saying.
I defer to Dr. Sprock to call us on it. It becomes so
I know
second nature.
he's been quiet today. He's been quiet. He usually nails us down. And Dr. Sprout, your hand is up. You're next.
Emesis is vomiting. So when they talk about hyperemesis, it's excessive vomiting. And antiemetics are medications to prevent the vomiting. But I wanted to ask Dr. Ali the issue of something that often gets thrown into this, and that's the issue of hiatal hernia and how that might present and how that might be diagnosed and how it might be treated. The other question is, and I started to raise it before, is there have been some associations with certain viral infections that might be associated with colorectal cancer. And one of them has been very, very closely associated with one of the female cancers, and that's the human papilloma virus, or HPV infections. And the question is, since it's so very prevalent, whether or not that and another virus called cytomegalovirus that has also been somewhat associated, whether or not those might be some things that might prompt some earlier diagnostic tests.
Well, I'm glad, Dr. Sprott, thanks for bringing up the hiatal hernia. That's actually a very important part, and I'll address that first. So hiatal hernias essentially are when there is a displacement between your stomach and your diaphragm. So we have a diaphragm, and a diaphragm is a muscle that is in the abdominal cavity, and it's essentially separates the chest cavity from the abdominal cavity in terms of the organs, right? So above this diaphragm is where we have our lungs, our heart, and then below this diaphragm is where we have our liver, our small intestines, our stomach, our spleen, and it's just a little thin muscle that kind of spans across the abdominal cavity, the body, right? Separating the chest from the abdomen. Now, sometimes, in the esophagus, this is a situation where the esophagus tracks down and it goes down past the diaphragm, and right at that level of diaphragm is where that transition is to the stomach. And that's all part of that sphincter, if you will, that's kind of all interplays in the same location. Now, what a hiatal hernia is where the stomach comes above that diaphragm, and that's the displacement itself. And when it comes above that diaphragm, a little bit of stomach tissue comes above that muscle, and it causes a little pinch at the level of where the hernia or the diaphragm is, and you can have a little bit of stomach tissue above the diaphragm, and that can create some issues with reflux, and it can cause more acid reflux and what we call refractory acid reflux. Now, when we do an endoscopy, we can actually look and see these hernias. The other way that you could see these hernias, or you could sometimes, not always, but sometimes you could see these hernias on an X-ray with a contrast or like a CT scan. And typically when we see these hernias, it depends on the size of them. Sometimes they could be really small. Most of the times they're really small, like a couple centimeters. And usually if it's a couple centimeters, we leave them alone. We kind of treat it as regular reflux. And the reason for that is because your body also, it's constantly contracting. The muscles along the esophagus are constantly contracting as part of peristalsis movement. And that movement can go kind of up and down, especially along the esophagus. And when we're going in and taking a look, it may be that we may see a little bit of a displacement, which could be related to the contraction as things move up and down. Now, if the hernias are larger, if they're more than what we call 5 centimeters in size, or they're creating a problem where there's a lot of stomach contents above the diaphragm, people have difficulty swallowing, then that we usually could undergo or refer them for a surgery to repair them. But we do not do it unless people are really symptomatic and they really need it. And the reason for that is because this hernia is in the chest cavity, behind the heart, between the lungs. It's a surgery that can be done, no problem, but it can come back. And there's a risk of it coming back. And a lot of times, if medications like antacid medication can control it, then that usually is what we would do.
Excellent. Excellent.
And then a question about the virus is associated with cancer.
So did you mean colon cancer or anal cancer?
There's been some associations with HPV, not only with anal or oral cancers, but also with colorectal cancers.
Oh.
Yeah, that
Kevin,
becomes a conundrum, because, as Kevin knows, the human papillomavirus is a virus that affects the surface covering. We call it the epithelium or the skin. It likes the skin, and it's a DNA retrovirus. And what it does, it tends to affect the lower genital tract. We see it in female, but it does affect men as well, causing penile cancers. But in women, we see it on the vulva, the area outside the vagina and around the anus. And it can be very expansive. More so patients who are immunocompromised, patients who are HIV positive, patients who are on suppressive drugs for organ transplant, kidney transplant, liver transplant, etc. When you see this, it can actually be quite impressive. And it can go from the pubic hair all the way around the rectum, where it becomes a problem for us, as you could understand based on the anatomy. When you have the HPV and it's just the low risk virus, which is just warts, and this has to be biopsy proven, because sometimes when you look at it, it looks like a cancer, but it really is not. So it's important that you get a biopsy both on the outside of the vagina, the penis, and anoscopy in the anus, because if it's not cancerous, or meaning invasive cancer, or if it's something precancerous, you can be somewhat conservative in the management, treated with antivirals, with laser, and so on and so forth. Where it becomes a problem is when it's expansive and it goes from the front all the way to the back and inside the anus. And this sometimes, I reach out to Kevin and say, how do you manage these pre-invasive lesions? Because as you can understand, if it's anal and it's pre-invasive, then, it's really a surgical disease. And oftentimes conservative management is not really helpful because the recurrence rate is high. But if you really do get the surgery that's required, then it becomes life-altering, meaning that now these patients sometimes require an ostomy, and I'll leave it to Kevin to explain all that. But for me, it requires Kevin's hands, it requires my hands, and oftentimes a plastic surgeon's hands, because the fallout from doing such radical operation is this kind of psychosomatic dysfunction, because sometimes it can be, to put it bluntly, disfiguring.
Yeah, the
HPV
was associated with, it's considered a sexually transmitted infection.
Correct.
But increasingly, it's been associated with throat and ENT cancers. And again, another reason, since there are vaccines to help prevent it,
Correct.
a reason for both men and women to get the vaccine.
Right, and
Correct.
not
And that's
because
what I was going to allude to, the Gardasil.
yes, but not because it affects the buccal oral cavity, the mouth and the throat, meaning it's any less of a sexually transmitted disease. Sometimes it comes down to lifestyle, and sexual lifestyle. But you know, to your point,
that was sort of inferred.
oh, okay. But yeah, you know, we grew up at a time pre-HPV somewhat, when we knew HPV existed, but the expanse of its influence was not understood. So we used to say, you know, for example, these throat cancers was, you know, the drinkers and the smokers. But now, you know, after being able to do these viral subtyping and testing these cancers, you know, we realize that there is a real association.
Dr. Ali, did you have something to say? Were you going to end on that one?
Oh, no, I agree. You know, I think as Dr. Sprott alluded with the HPV, right? It is a risk factor for these cancers. And it's one of the reasons as well. And it justifies the importance of the HPV vaccine, right? Which is now something that we can give for men and women starting at in the teenage years, right? I think starting at the age of 13 or 14 now. No, I think age
Actually,
12.
age 9. We
Age
start
9. Okay,
as
there you
early
go.
as 9.
Yeah, I mean, the key is to try and get the vaccine before you actually get infected.
Exactly.
Because once you get infected, it's not that easy to get rid of.
Right. And women can and men can be vaccinated up until around age 45. If they're right. And just so you know, for men, you know, we do pap smear in women, cervical, vaginal, but also an anal pap smear can really be revealing as well.
Alrighty. You know, Patrick, you had stated and you brought up one word. It's called an ostomy, and you said Kevin could explain what that is. I don't want to pass that over because we say things and we don't. The audience
So
may not know what it is. Just simply, what is an ostomy?
an ostomy is a creation, I don't want to say abnormal, but it's a creation where instead of the intestinal tract being in continuity all the way down to the anus, sometimes we have to divert it and bring it through the abdominal wall up to the skin. So it could be the small intestine or the large intestine, and it's done in situation. There are many different reasons to do it. It could be part of a cancer operation. It could be part of an operation for obstruction. It could be part of an operation to divert the stool to facilitate the healing in the perineum. So the specific case that Dr. Anderson was talking about, when you have a tumor in the vaginal area or in the anal area that's fairly extensive, the operation sometimes involves a pretty disfiguring procedure. And during the healing process, we don't want to have stool come down in that area, which is the normal route. So instead of having stool go through the anus, we divert it proximally with a colostomy, which is bringing the intestine through the abdominal wall. And patients will have bowel movements in a bag on the abdominal wall as opposed to the regular bowel movement.
Alrighty, excellent. Dr. Nelson Aluya, I see that he is in a car riding, being chauffeured, it looked like. How are you doing? Can you introduce? All right, brother. Can you introduce yourself? I'm jealous. I'm doing let you know I'm jealous.
I know. I had to do 2 speaking engagements today. One for a big one in Nigeria to some brilliant young kids who are doing innovative services to change the African continent. So it was quite good. And then another one at the SF County College where we had to talk about mental health and other issues as it concerns to us as Black men. So it's a pleasure, and I couldn't miss it. I needed to come. So as soon as I finished, I just joined in. So again, it's Nelson Aluya, medicine and pediatrics trained. I needed to put that there. My big brother is watching, Dr. Sprott. and a medical advocate, consultant, the healthcare services, St. James. Just a good old brother who's working hard to make sure our community is safe and they are heard, seen when it comes to healthcare. Thank you.
Excellent, brother. And we need you out there too. And I appreciate you going from place to place, pounding that drum, man, because we need it. I have a question, Dr. Sprott. Being a pulmonologist, I can't let this go. You were talking about the babies and they're not vomiting the milk, or feeding, so but it was just coming up. What's the concern for aspiration?
Usually with the burping,
Mhm.
they don't usually aspirate.
Right.
It's sort of a relaxation. The milk sort of comes up, and
Mhm.
they either spit it out or they swallow it. Usually, aspiration occurs from choking, and that's not something that frequently occurs with reflux. And
Right.
vomiting, it's sort of as I said, it's a forceful action, and it's actually projectile out. And so the only time that you are concerned about, I'll say aspiration, where you have something that goes into the airways, as opposed to uh, reflux, where it just sort of stays in the esophagus, comes up to the throat and out, is if someone is happens to be on their back and they have something that goes in. Usually, if the baby's on their stomach, that's not how we like for them to sleep. It would come out. But in general, babies when they do have those issues, it usually goes to the side. It isn't something that they usually have with aspiration.
Right. Right.
Children that have certain kinds of developmental delays, where they may have issues in terms of control of their swallowing and things like that, will be more prone to have aspiration than individuals that have normal neuromuscular access to the swallowing mechanisms.
Mhm. Dr. Ali, um, we have a few questions for you
All right.
already. And the first question is from me, obesity and GERD. Is there an association, do you think?
Absolutely. So as we gain weight, if you gain weight, you have an increased, you can develop more reflux based symptoms. And part of that is because of the stretch itself that can occur at the lower esophageal sphincter, stomach accommodation, overeating. Unfortunately, all of that adds to more reflux that can develop. Is so for folks out there who may notice that reflux symptoms are occurring and it's because there's been a little bit of weight gain, some in those scenarios with weight loss, the reflux could go away and you may not need the medication.
Mhm. All righty.
But
We covered,
what
thank you. Go ahead. I'm
Yeah,
sorry,
I was going
Patrick.
to ask, along the same line, we see a lot of these newer medications, these injectables that are used for diabetes. And from a surgical perspective, Kevin can agree with this. We're having some issues now with gastric emptying and counseling patients regarding using these. Are we seeing more GERD with some of these GLP-1 medication?
Absolutely. And I'll actually, it's one of the newest and more common referrals that I'm starting to see.
Hmm.
So these new medications that we have out there to treat reflux, right? These are medications like Ozempic and Wegovy. And these are medications that are used usually to treat reflux. I'm sorry, they're used to treat diabetes, to control the diabetes. But the way they work is by slowing down the stomach emptying. So what it does is it induces things at the hormonal level where your stomach slows down, you get full quicker. It's called early satiety. But what can happen there as well is that because you're developing kind of a slower emptying, you can have more acid building up in the stomach, and that can lead to more reflux. You also, I'm seeing a lot of issues with things like constipation. So it can cause more bloating, gas, distension, trapped air, and and constipation. So these are some of the things that can develop with these medications. They're very popular right now because it's almost like a fad with like a trend with weight loss, but really it's used in the setting of diabetes. It can be used as a weight loss medication as well, but I do recommend speaking with your doctor about the risks, benefits, and if somebody has chronic reflux, they've got issues with constipation, it may not be the best drug or medication for them. At least they need to talk about that because expect that could potentially get worse. So yes, I'm seeing it all the time now.
All righty. Doctor, we got two hands up. Dr. Aluya, and I'm just going to say that we only have like about 20 more minutes. So, and we got quite a few questions. So we're going to take these questions and then we're going to jump into the questions that are coming in from where Dr. Aluya. Yeah, Dr. Aluya, go ahead.
Right, right. So I was just going to add to that and then ask my big brother a question. With regards to diabetes and the GLP-1s that we're seeing, understanding that the autonomic complications of diabetes actually can begin in the pre-diabetic stage, and that's one of the things a lot of people don't pay attention to, and they really can be very severe depending on who you're dealing with or who and for how long you stay in the pre-diabetic state. Now, one question or two questions, for you, Doc, is this. One, is it possible that the GLP-1s, knowing that they act more on the GI tract, are exacerbating the autonomic complications of diabetes, which is gastroparesis? And the other question to that is, how do you begin to truly manage this gastroparesis as it occurs?
That was my question too. So we can kill two birds with one stone. Okay,
Right.
talk.
That's a concern.
Dr.
Yeah,
Ali?
you know one thing, and it's a great question, and it's something that's come up even in as far as nutrition is concerned. The thing of it is that and I don't have an answer. I think that we may need to get more study as far as get out further with these medications because they're too new to really answer that question. Dr. Ali, maybe you can get it. Get it. Give us.
Yeah, so gastroparesis is a condition where we have slow emptying of the gut, right? And when we think about complications with diabetes, some of the long-term complications of diabetes, the common ones that we see are things like the heart disease. Sometimes people could develop issues with the eyes or even neuropathy in the feet where they get like a tingling sensation in the feet. But then there's this other condition that can develop as well called diabetic gastroparesis, where it also affects some of that autonomic system and you lose the ability to contract and empty from the stomach. Now, what's interesting about gastroparesis, it's one of the end stage, like later stage complications that can develop with diabetes. I do rarely see it early on in some people, and sometimes it's not necessarily associated with high sugar levels. Sometimes it is, and sometimes it isn't. So it's a little strange in how it can present, but we do see it. Now, whenever we see gastroparesis, the way we diagnose it is with the symptoms. I usually would do an endoscopy to make sure there's nothing causing a blockage anywhere that could be driving it, because the symptoms could be very non-specific. But then also we do a special study called a gastric emptying study, which is a special type of test where you eat something and we see how fast it can empty out. Now, in terms of, with these GLP medications, there is not a clear link that it's causing, it's related to that end stage. But when people have gastroparesis as a complication of their diabetes, I caution them, if not, I usually don't recommend these class of medications because it can make it worse. What it's doing is it's inducing gastroparesis. That's the point of the drug. The point of the drug is it's going to make you full quicker and it's going to slow down the emptying. The issue is how much is it slowing it down where people are really symptomatic. If they're really symptomatic, because it can hurt. It can be, you can have a lot of bloat, gas, distension. It could be very uncomfortable. And if that's the case, I get them off that medication. When I treat it, I usually try the conservative measures, things like small, frequent meals. I have if I can, maybe get them to a nutritionist. Sometimes we can use things like Reglan, which is a medication to help speed up the system a little bit. We could use it a couple weeks at a time. We usually don't recommend longer term, but sometimes if the symptoms are severe, yeah, we do it. There are some other medications that are slowly coming out. There's one that's approved in Canada, but not yet approved here in the United States, called domperidone. It's been around a long time, but it just hasn't been FDA approved. And even Reglan, there's a new formulation of Reglan that is with it's an intranasal, which you can spray in the nose. This is kind of newer stuff that's coming out that's come out in the last 6 months, that doesn't have some of the neurologic-based side effects that have been reported. I haven't used it yet. It's just come out, so I think it's going to take some time for us to get some experience with these. And then the more severe cases, there is even interventions we can do to try to open up a little bit more of the stomach, to try to see if it can accommodate some food to pass into the small intestines. So there's a few things that we can do.
I have one question. With the diabetic gastroparesis, and that's a nerve problem, and as you said, an autonomic nerve problem. If the GLP-1s if they're doing something similar as far as slowing up the emptying, is that nerve problem, number one, exacerbated? And if you take them off the GLP-1, is the nerve problem chronic at that point? It will not reverse back to normal, if you understand what I'm talking about.
So my understanding with the GLP-1s, it's blocking ghrelin. So it's blocking a hormone that's kind of creating kind of that sensation of early satiety, not necessarily working interplay with the actual nervous system, but it can create a similar effect.
Right.
So it's almost two different mechanisms. But if you were to you have diabetes and you develop these symptoms on the medication, you stop it, and if they persist after a few months, sometimes it could take a little time for the medication to kind of come out of the system. I usually would consider a workup to see if there's true gastroparesis related to the diabetes. Right. I hope that answers your question.
Yes, it did. Any other questions? This is great. I'm going actually in the future we'll try to bring someone on that their specialty is the GLP-1s and get more info, because it's just so it's being widely used at this particular point. Let's get to some questions real quick. Good day. And Dr. Ali, you covered this, but the question came up again, so maybe we need to just hit it really quickly. What causes diverticulitis?
So diverticulitis, again, that's an inflammation of the diverticula, right? And a lot of times we don't know exactly what causes it, except the fact that there's a little bit of stool that gets caught in that little pocket, and that can close off and create inflammation. So some things to prevent diverticulitis would be fiber. Fiber helps to bulk in your stool, keeps it a little bit more formed. So it prevents these little stool balls from just kind of getting stuck in those little pockets that creates the issue. Now, I'll address this part because it's a common question that I'm asked about, and that's seeds and nuts. And seeds and nuts, when we look at the data, actually, there's no data that says avoiding seeds and nuts causes diverticulitis. If anything, seeds and nuts come from sources of high in fiber, and that's good for you. So I usually don't recommend to tell patients stop seeds and nuts. As long as they're keeping high fiber in their diet, it's okay. There was a study that came out years ago that really refuted that seeds and nuts were a trigger for this. So it's low fiber foods that I try to avoid, sticking with high fiber. If you don't, or that's hard for folks to do, then at least supplement with a fiber supplement like Metamucil, Citracel, Benefiber, some sort of a fiber that gets in there and just kind of helps with the microbiome as well as the stool. So.
Excellent. Another question. I was diagnosed with gastritis and was prescribed famotidine, 40 milligrams. I have stopped taking the medication prescribed and now on Tums. Should I go back to the medication?
So it really depends on the symptoms, right? Now, famotidine is safe. It's something that if you need it, you can take it. But if you don't have symptoms per se, right, of pain, discomfort, heartburn, reflux, then it may not be something you necessarily may need if there is a history of ulcers in the stomach. And if there's a history of recurrent ulcers, or you're on a medication that leads to an increased risk of developing ulcers like Motrin, naproxen, Aleve, ibuprofen, aspirin. These are medications that can cause an increased risk of things like inflammation in the stomach, gastritis, or even ulcerations. Then it doesn't, I would recommend keeping on something to protect your stomach. But if you're not on these medications, you otherwise feel well, then usually it's not something we would recommend. But I think it would depend on the patient and the context. How severe is the gastritis? Was it H. pylori associated? I would want to know those things as well before saying, well, you should be on this thing for all, for the long term, right? We also want to be in a spirit of not putting somebody on a medication and having them on it forever if they don't need it, right? If they have an ulcer, we treat the ulcer, then we get them off the medication if they're feeling well. But if they've got a condition that really warrants it, like Barrett's esophagus, recurrent heartburn, ulcers, and they need to be on blood thinner medications or medications that may increase the risk of it, then it's reasonable.
Right. Excellent. Dr. Aluya, you got your hand up.
Yes, so this is for Dr. Ali. Often enough, we see people placed on H2 receptor antagonists. And unfortunately, they are on this Prilosec, omeprazole, or Protonics for a long, long time. And over time and age, we've come to understand, the risk of re-epithelialization and the gist, complications that, that we have. So could you please tell us and our community, if you're on Protonics or any of those medications, how long would you take them for? And is it okay to do a washout period, meaning stop and restart, those meds?
Yeah, Dr. Leo, thanks. That's a good question. And I think a very helpful one for everybody. So, these medications, as I mentioned, have been around a long time. And it's not uncommon for me to meet somebody in my office, right? All of us. And you look at their medication list and they've been on omeprazole for like 20 years, right? Or they may be buying it and taking multiple doses of these medications. I met somebody the other day that takes 4 pills of omeprazole 3 times a day to treat the reflux. And I was like, oh my God, you got to get off of that. But, what I can tell you is this: reflux is very common. And if the reflux is something that occurs regularly, more than 2-3 times a week, right, then that person would probably benefit from being on an antacid therapy to prevent. And it depends on how severe it is. Now, in anybody that is usually, if there's a 20 plus year history of reflux or even a chronic history of reflux, right? And what often I would do, and if they require the antacid, that's okay, because it controls the reflux. If you get them off the medication and the reflux comes back, that's also a poor quality of life, and it can increase the risk of development of Barrett's esophagus, right? So there's some scenarios and some situations where these antacids are needed and they're safe, right? They're controlling something. Now, so my recommendations are, A, if you've got chronic reflux and you feel like you need to be on something, that's okay. But do the lowest effective dose. If your lowest effective dose is 20 milligrams once a day, great. I have some people that need to be on 40 milligrams once a day or 40 milligrams twice a day. If you're at that level, you should be at least if you can, see a GI doctor. Ideally, if we can take a look and screen you for Barrett's and really determine if those things are involved here, I think it would be important and helpful for that patient. Now, the key is lowest effective dose. If you notice that people have been on it for a long time and they have none of these risk factors, you could give them a trial off of the medication. You don't need to wash them out. You could just stop it, right? I even have some people that you could take it on demand. I know that sounds counterintuitive, but it says on the bottle, take 30 minutes before a meal. It also says don't use after 2 weeks. These are all labelings that are important when you're using it in the outpatient setting, because we don't want patients to just take this thing blindly forever, right? So I have sometimes patients that need an annual prescription. If you feel like you need it more than a couple weeks, you should be seeing your doctor so you can get the annual prescription, or at least a 90-day. It's cheaper that way. But ideally, you could take it also on demand.
Excellent, excellent. There's another question, and I'm going to go through these because I just think it's important to read. This is an anonymous attendee. Thanks, everyone. This is very interesting and presented in terms that a non-medical person, for non-medical people, I should say, highly appreciated. So that's just some good stuff for us to hear. As doctors, we're doing all of this. It's nice to hear this every once in a while. Congrats, Dr. Kendall Sprott. Well deserved. Someone says that's an anonymous as well. All righty. And then we have, let me see, Miralax. Okay. Is using Miralax daily to help constipation harmful? That's a question, Dr. Ali.
It's a very good question as well. And Miralax is actually my go-to. When people suffer from constipation, it could be for a variety of reasons, right? And ideally, when is the ideal bowel movement is the other thing I get. Like, should you be having a bowel movement every day? Some people, they can have it every day. Great. Some people have bowel movements 3 times a day. If that's their speed of their bowels, that's okay. If you have a bowel movement every other day, no problem. If it goes beyond 3 days and you've got symptoms of bloating, pain, discomfort, you probably would benefit from being on something to help you to go. So my first line usually is fiber, like a fiber supplement. It's the most natural thing. It's great for the microbiome. Something like Benefiber, Citracel, Metamucil. The cheapest one is fine, right? But a fiber supplement could help you to have a bowel movement. Now, if that doesn't work, then Miralax is my go-to. And the reason why I like Miralax is it stays in the gut. It's a molecule that brings water into the system to allow you to have a bowel movement. And we've got patients that are on it. It doesn't interact with medications. It doesn't metabolize through the kidney or the liver. It just brings water into the gut. It comes in the gut, exits the gut. You could take it once a day. I have some patients that need to take it up to 3 times a day. It's what I've got my centurions on because it doesn't interact with medications. Now that works maybe about 50-60% of the time. If it doesn't work, then we think about other medications that are FDA approved to treat the constipation. Now, I will say this, if you've got new onset constipation, and you haven't had a colonoscopy, right? And you're within that colon cancer screening age, then that should get evaluated, right? So don't use the Miralax just to control the symptoms. The thing we need to think about is why. Why do you have constipation now? And let's figure that out.
Excellent. Dr. Sprott, please. You're on mute, Dr. Sprott. You came off and came back on.
Am I good?
Yes.
You're good.
Yeah, constipation is a fairly common problem in pediatrics. And it can be very disturbing to the parents. And the frequency of bowel movements, as Dr. Mazur said, can vary, especially with newborns, especially if they're on breast milk. Very often when they initially start to have stools on breast milk, they might have a stool every time that they feed, which could be every 2 to 3 hours. But somewhere along the line, within several weeks, the stool frequency may change. And as long as it's still on breast milk, they can go once every 5 days, once every 6 days, once every 7 days. But the consistency of the stool is still the same, which is the consistency of uncooked scrambled eggs. And as long as they're having that kind of a stool, we don't worry about it. But the older children, once they start to get on the solids, they may have issues. And it can become a really chronic problem, because what happens is that as the stool stays in the gut, especially the lower part of the gut, water is extracted from the stool, and the stool starts to become hard and dry. If you think about it, if you pass a stool, the hardest and driest part of the stool is the stool that's been there the longest period of time, which is near the exit point. And once you pass that hardest part, driest part, then the rest of the stool becomes significantly more moist or wet and easier to pass. But if a child experiences discomfort in passing that first hard part of the stool, they'll not want to experience that discomfort, and they'll just continue to hold on to the stool until they can't do it anymore. And then they'll, with a lot of discomfort, pass a stool, and it'll be a huge stool. Some parents complain. They said, I can't believe that the child passed something that large. It becomes that type of an issue. And so the treatment, and my go-to is same as Ali's, is that, you know, I advise that they use Miralax. And one of the problems that you encounter in pediatrics is a lot of the medications that you might use has never been studied in children. And the pharmaceutical companies don't like to study in children because the risk associated with that might be for 20 some years, and they don't want to take the risk, and so they don't do it. And so very often what happens is that the pediatricians or the specialists may start to use it, and they'll come up with dosing that they find works. But you know, some of these parents, they're on the internet and they said, oh, it's not recommended for a child under 4. And I said, that's just not the facts. We've been using it for years and years. But the treatment for it is a long treatment. That means that they need to use the Miralax every day. And remember that if the child's been going once a week, it may be another week you start to use it, and they may have another stool that's just as hard and just as that. And so you need to continue to use it until the child starts to pass stools that are soft, and they get over the fear of the discomfort, which may take several months. Okay? And again, once you start to have stools that are soft and not difficult to pass, they still need to continue to use it because they will have had a problem with the tone in the rectum that may take some time to come back. And so I say, you know, do it until the child feels comfortable with it, and then continue to do it maybe for another month or so until the child is completely okay. And then as that tone starts to come, and you'll see that the sides of the stool will start to become normal. But I feel very, very comfortable with the use of Miralax on a constant basis. But again, the parents need to be vigilant because if indeed they go through this period of time where the child is no longer having the constipation, passing a normal type of a stool, it can come back again. And so if they're starting to have decrease in the frequency, they'll come with the same kind of pain, they'll get the discomfort, and they'll get that same mindset again. So it is a common problem. It is something that is not a quick fix, and the parents need to understand that this medication is okay, and that the child needs to get over the discomfort, and then the child needs to get the rectal tone back to normal before you can say, okay.
Excellent.
And again, once you finish, be sure that you have a good portion of fiber in their diet that helps prevent the problem in the first place.
Excellent.
Oh, one other thing that was mentioned before, in terms of the GERD and the hyperemesis, the women, you know, the old adage of ginger ale and crackers was used, but there is some evidence that ginger can be helpful with both the GERD as well as the vomiting, but it needs to be a lot of ginger, not the amount of ginger that's found in something like ginger ale. They need to make a ginger tea or make something that has a significant amount of ginger in it if it may be helpful at all.
Excellent. Excellent. Thanks, Ken. We have two or three more questions. Let's get those out of the way. Can you please talk about the use of probiotics or prebiotics, Dr. Mason?
Sure. So very common thing that's readily available and a lot of information online, right, about this. Now, and you're going to get a lot of different opinions on this as well. So, and this is mine, essentially. You know, when we look at the data and what's been published out there, the data has been very spotty, meaning that you've got some studies that may show a benefit and you may have some that don't show a benefit. And it depends on the condition as well. What we are seeing, though, overall as a trend is you can see that probiotics are very helpful. And again, this is the data, right? Very different than the individual. But probiotics are not really shown to be beneficial in the setting of irritable bowel syndrome, diverticulitis, or any of these other conditions. It is useful in one particular situation where people have something called a pouch, and that's when in a condition such as ulcerative colitis or Crohn's, with the colon has to be removed, and they reconstruct a new rectum, right? And people can develop inflammation from that. There is data that shows that probiotics can help in preventing something called pouchitis. Now, with that being said, right, I get asked this all the time about, well, which probiotic, and we really don't have good data to say which probiotic works better than the other. And a lot of what's out there on that is marketing. And marketing has really been pivotal in convincing a lot of minds, but that's all driven by money. It's all driven by the economics. But when we look at the science of it, right, I just don't have enough that makes me confidently with certainly tell somebody try this probiotic, because I don't want them to spend money on something they don't need to spend money on. And these probiotics are expensive. You go to the grocery store and a little bottle may cost you $50, and there's no good data to back it up. Now, it may say on their company there's data, but that's biased data. We have to be cautious about the kind of data that we see and how we interpret that data, and because you want our data to be reproducible and reliable. And and that's something that as physicians, as medical providers, that's something that we're trained to do at the core of our profession, right? In medical school, we sit down in first year and we learn how to take a study, because not every study means it's legit, but how do we take that study and make sure it's absolutely reliable? It's my mentors always used to tell me, garbage in the study means garbage out the study, right? So and unfortunately, probiotics and the story of probiotics, a lot of it is that. Now, does it hurt? No. You can try it. If I tell people, if they really want to try it, and if it feels like it helps them, I have some people that tell me, you know what, this probiotic really helps me. And I said, all right, go with it, roll with it. But if it doesn't, I wouldn't get hung into it.
Excellent. Excellent. Thank you. I appreciate that. Next question. If you have had a history of colitis, did I do this? Oh, no, no, no. All right. If you have had a history of colitis and have not had any any flare-ups in the last 5 years, can colitis come back if eating enough, well, check this out, fiber and avoiding dairy, onions, garlic, etc. So can colitis come back, in other words?
So it depends on the colitis, right? If there is a diagnosis of something called ulcerative colitis or Crohn's colitis, these are the autoimmune-based conditions that can cause colitis. There's also something called ischemic colitis, where you may have a little bit of a decreased blood flow in the colon causing that, right? Or people may develop a flare or like an infectious colitis, an infection causes it, usually goes away. It depends really on the type of colitis. Now, things like garlic, onions, they can cause more gas in the system. And that can make people feel bloated, gassy, may give them a little bit of a looser stool. So if that's the case, I recommend to avoid those things because they could be culprits. But usually if it's a condition like an autoimmune-based condition like ulcerative colitis, that requires potentially medications or just monitoring to make sure it's healed, because sometimes the symptoms don't correlate with the inflammation that may be seen. You could still have active inflammation in your colon, but feel great with 1 to 2 bowel movements a day and you're not having any problems. But the problem is that if you were to leave that and let it go, and there's still inflammation, you feel good, and it's not being looked at, and you're not on medications to control it, that can increase the risk of colon cancer after 10 years, 8 to 10 years, right? The risk goes up. You want to heal that lining. That's the standard of care. So it depends again on the type of colitis.
All righty, excellent. Another question. We got some good ones here. Do you recommend flaxseed? Daily question. It says daily question. Oh, question, Dr. Ali. That's what it is.
So flax seeds are good, right? I believe it definitely helps with things like lipid panels and cholesterol. But really the crux of where the benefit is in the colon is fiber. Fiber actually is, if you want to call like the ultimate probiotic, it's fiber. Fiber will promote things like butyrate forming bacteria, which is a good bacteria in the microbiome. It's fuel for that. And ideally, like as I mentioned, about 25 grams of fiber a day. And it helps in fueling the good bacteria within our microbiome so it can thrive. So, and I usually recommend soluble-based fibers because fibers are long sugar, like long chain carbohydrates that can cause gas and bloat. And if people suffer from that, something like benefiber, citrusel, or like psyllium, right? These type of formulations of fiber are more palatable to the gut where there's less bloating and gas, and they're very beneficial in promoting microbiome health, preventing complications of diverticulosis like diverticulitis or bleeding, and just feeling better. Bowel regularity.
Excellent. Our last question is the yogurts still good that has probiotics? I think what they're talking about, yogurts with probiotics. Okay, go ahead.
So yeah, I think that I always tell people if you want to feed your microbiome, you want to do things to make your microbiome healthy. The one thing that the microbiome is sensitive. It's like, and you don't want to poke the bear, right? So sometimes people are coming into my office and they're on multiple probiotic supplements, and I tell folks, you know what? The microbiome is going to take exactly what it needs out of the foods that you're eating. So the key is avoid processed foods, high fiber foods, foods that have good bacterial strains in them. That's great. Yogurts, kimchi, tempeh, right? These are things that are fruitful for your microbiome, and it'll take exactly what it needs out of it so it could thrive on its own. So yes, I'm a big advocate for things like yogurts. I avoid the ones though with lots of sugars in them. Because that sugar could be a problem. But the other good part of yogurts is the source of calcium, right? A lot of people avoid the dairy or something else, and if you can tolerate it, I say go for it for the calcium source as well.
Excellent, excellent.
Dr. Ali, what's a microbiome?
So the microbiome is essentially the center of your digestive health, but also it plays a role in your overall function, your overall metabolism, your well-being. And this is a conglomerate of bacteria, good bacteria that live within our guts that help with your metabolism and your digestive function. And what we've learned over the years is that, and we're still learning a lot about the microbiome, it's a very powerful part of your digestion, is that it helps with digestion. And sometimes if there's an imbalance there, is how we're seeing the interplay of things like autoimmune diseases, infections, general illness. So we try to do what we can to promote that microbiome. The problem and the key though is not to overflood it. Again, it's a sensitive being. So probiotics aren't the answer. It's diet. If you want to optimize your microbiome health, it's eating the foods that will promote that. And a lot of it is avoiding the processed foods, avoiding the red meats, the high fat foods, healthy fats, things of that nature. That's the key of how it can thrive.
Excellent. We're gonna end right there. I'm going
Sorry, I think if you don't mind, just one thing. I hear this all the time. Colon cleansing. I'm not sure if you did talk about that before. We hear people come talk about it. I'm going colon cleansing. What's your take on that?
I am not a fan of it at all. I actually have seen my fair share of complications from it. It can cause barotrauma, which is trauma to the colon itself. The colon is not to be designed to be washed out with a hose, right? We do a bowel cleanse for a colonoscopy, and that's fine, and how it cleans out. But these colon cleanses, they wash out the good microbiome. They have pictures of all these things that are in the colon. There's no data, and I strongly advise against it. I think I see the complications from it, and I see them more too often than not.
Excellent, excellent. So we're going to end right there. Great question, Dr. Aluya. Great question. And I have to say this. Next month, unfortunately, we're not going to have a webinar next month in December. We're going to give everybody a Christmas off. How about that? December, I will be away at a wedding, and the wedding is exactly the same time as the webinar. So we're going to give December a break. We'll be back in January. And January, of course, we love to have a female on talking about a female medical female problem from a medical aspect. So we're looking forward to that, and just looking forward to a great year coming, because I think this year we covered a lot of topics this year. I think we have many more to cover, and I'm looking forward to 2025. All righty. Let's close here. Thanks, OBHealthy, for allowing us to use your platform so that we can bring this webinar to you. Again, without them, we wouldn't be able to do this. Remember, every second Saturday. We are here at 1 o'clock. Tell friends and family, tell church members, because it's all about educating our people as far as their health is concerned. All you have to do is come into OBHealthy, click the doctor's lounge or the doctor's area and come into the doctor's lounge and just register, and we open up and we'll answer any medical question. Remember, caring and sharing. We're caring, and please, you guys out there, do some sharing the knowledge, and also just let people know that we're here to help. The most important thing that I can say today is please do not change any aspect of your medical care. Only your doctor, believe me, only your doctor can truly take care of you from a medical standpoint. All right. And if you want to see any of our past webinars, please just go to the website, hit the YouTube sign, and all of them will come up. Plenty of topics to cover. And I'm going to end right there. I'm going to say peace out there. Enjoyed each and every one of you, brothers. All right, peace. We're going to see you in January, December. We're going to give it a break. All righty. And we'll be rocking and rolling. Peace.
Happy holidays to everyone.
Right.